Hello, Honorable Prime Minister Mr. Narendra Modi and BJP Party. This policy brief discusses TB treatment and screening in India and possible alternatives to combat this endemic disease. The aim of this policy is to adopt measures to provide mandatory screenings and treatment options for TB in India. Yearly, TB kills nearly 500,000 individuals in India, while over 1 million are either undiagnosed or undertreated. Due to the highly contagious nature of the disease and high morbidity and mortality rate in South Asia, it is a necessary focal point for public health officials, lawmakers, and healthcare providers. There are no unified training or guidelines in place, such as required use of proper protective equipment or adequate airborne infection control to prevent spread from one patient to another. Because of this, there is a high prevalence of latent and active TB among healthcare workers in India as well. The first national anti-TB drug resistance survey created by the Indian government, WHO, and the United States Agency for International Development showed high multi-drug resistant strains of TB to first and second line drugs. Drug-resistant TB is rampant in India with the highest number of cases in the world. We will go into more detail about India's revised National TB Control Program later on, which gathers funds and donations from the World Bank and WHO. Currently, funding for this program does not match the disease burden in India and does not provide enough support to successfully implement plans to combat TB. The magnitude and severity of the problem is underestimated due to poor national health surveys and tracking systems, as there are no mandatory reporting in place. Currently, the BJP set a goal to provide universal access to treatment and TB diagnosis through the revised National TB Control Program National Strategic Plan. This plan relays TB as a national public health emergency and details the need to pool resources to ensure eradication. The government declared a war against TB by instituting a goal of ending the spread of disease and decreasing disease burdens by 2025, only 6 years away. The plan claims responsibility to regulate Indian pharmaceutical companies so as to provide accessible medications for prophylaxis and treatment. Also, investments for safer medications with shorter duration of treatment may ultimately increase compliance and willingness to receive treatment. Regulation of the private and public health sectors is recommended to ensure patients identified as TB positive are monitored and adequately treated regardless of socioeconomic status and ability to pay for treatment. Looking at the overall disease burden of TB in India, the annual risk of infection is estimated at approximately 1 to 2%. Additionally, there is an increasing trend of drug-resistant TB due to flippant antibiotics, regulations, and guidelines in place. Although the prevalence of TB has decreased by 37% since 2012 compared to 1990, there is still underreporting of incidents and prevalent cases due to lack of unified reporting system, as aforementioned. All Indians have a right to health and quality, and the scope of the RNTCP is to provide adequate treatment options and rapid diagnostic exams. National government must work in conjunction with state governments to employ practitioners in rural settings and elucidate the need for multi-sectoral collaboration to raise funds for the TB-free campaign. There are economic losses of nearly $43 billion due to disease burden, with almost 100 million workdays lost yearly. We need to make TB eradication possible, as was polio eradication in the country. The current healthcare budget is only 1.4% of the country's GDP. We need to increase this to at least 2.5% according to the National Health Policy 2015 draft to adequately fund programs to combat TB for the entire nation. Delving into the cost-benefit analysis, it is cheaper to educate the population, decrease overprescription of antibiotics, and invest in future TB research and drug manufacturing. Additionally, we need to consider the proximal and distal causal factors that lead to higher prevalence of TB in different social strata. Consider malnutrition, outdoor and indoor air pollution, and prevalence of smoking and pre-existing pulmonary conditions. By improving living conditions, sanitation, and creating a conscious urban environment, we can combat the root cause of this infectious disease. Lastly, there is a need for notification systems in private and public sectors to contain the spread of TB. Millions are not diagnosed or have delays in treatment. The advent of technology, along with unifying standards of care, requires a higher budget than what the government currently proposes. There must be an increased quality of care for patients and outcome-based practices implemented in clinics and hospitals, as well as investments in research and cheaper medication manufacturing options. The first requirement is to increase the GDP allotment for healthcare services and then to provide funds to sustain TB programs across the country. The status quo involves the RNTCP and its goal providing universal access to diagnosis and treatment in particularly vulnerable populations where disease burdens are highest. The hopes of finding more cases earlier via enacting social mobilization prior to hospital presentation will allow for spread of disease. Due to the decentralized basic TB control services, there is no unified system of tracking patients diagnosed with TB. Additionally, there is a need to regulate companies and distribution of medications to combat antibiotic drug resistance. Each drug-resistant TB case costs over 1 lakh, which is roughly $1,445 US. An alternative proposed is to build upon the initiative created by the WHO called Find, Treat, All to bridge the gaps in TB screening, diagnosis, and treatment in disease-ridden areas. There is a dire need to create a national accountability system that keeps tabs on patients. To do so, we need funding to hire more public health workers to engage in communities and track disease burden. This will allow for personalized treatment options for particular communities. By comprehensive tracking, one can get a better idea of how infectious disease spreads and how best to combat and contain the disease. We need to target patients who are younger, those with pre-existing infectious disease, and impoverished communities. Having smaller local government involvement can be the best way to care for hard-to-reach communities. However, one particular limitation to this alternative is the fact that it would take a large group of public health workers and resources to complete comprehensive surveys of all neighborhoods in India. This would comprise of a multi-year project to illustrate which communities are most affected and where aid should be prioritized. Our second proposed alternative is in relation to the first alternative. We suggest a reorganization of the current healthcare infrastructure and practices. The overall GDP to cover all health-related funding and projects in India falls short to make any changes in population health. A focus should be on drug-resistant TB, as this is the primary obstacle to overcome TB-related morbidity and mortality. Additionally, the creation of unified TB control strategies should be used in all hospitals and employed by all healthcare personnel. Simple, cheap routes to lower TB infection rates, like personal protective equipment and N95 respirator masks, can drastically reduce the amount of healthcare workers exposed and can reduce the spread from patient to patient. The use of rapid assays to detect pulmonary and extrapulmonary TB can provide results in less than 2 hours and simultaneously test for drug resistance. This is an absolute game changer as it lowers the risk of positive TB patients returning to society and potentially infecting more individuals. However, similar to the first alternative, restructuring of healthcare systems will take a number of years to implement, with numerous policies requiring for approval. Yet the simple steps to decrease disease spread, such as the use of respiratory masks, are quick fixes that can have profound impacts. An increase in the national GDP expenditure on healthcare to sustain the RNTCP programs and WHO-related interventions is necessary, along with extensive public health training programs. Community involvement programs fostering advocacy and education can help keep residents accountable for their health. As well, creation of inclusive treatment and diagnostic guidelines for all healthcare workers to reference while treating suspected or diagnosed TB patients will decrease the spread of disease. Pharmaceutical regulation will decrease antibiotic use and rogue off-market formulations. Thousands of rural communities do not have access to proper healthcare, sanitation, or education. One of the driving factors for a majority of public health initiatives is to directly involve community members in their own well-being and health. We need to be wary of cultural differences and belief systems while implementing these policies and approach each community with respect. Because a large percentage of individuals infected with TB are poor, perhaps financial incentive systems could be in place to ensure compliance with medication and treatment adherence. However, this needs to be included in the overall budget for RNTCP and WHO projects. In conclusion, TB has claimed millions of lives yearly within India and globally. With the correct tools via medication, training, and supplies, as well as scaled strategy via notification systems, community outreach, and education programs, it is possible to significantly reduce TB morbidity and mortality within the Indian population. Thank you for your time.